Welcome to the Culture of Healthcare, Sociotechnical Aspects, Clinicians and Technology. This is Lecture C. The component, the culture of healthcare, addresses job expectations in healthcare settings, including how care is organized within a practice setting, privacy laws, and professional and ethical issues encountered in the workplace. The objectives for sociotechnical aspects, clinicians and technology are to describe the concepts of medical error and patient safety. Discuss error as an individual and as a system problem. Compare and contrast the interaction and interdependence of social and technical resistance to change. Discuss the challenges inherent with adapting work processes to new technology. Discuss the downside of adapting technology to work practices and why this is not desirable. Discuss the impact of changing socio-technical processes on quality, efficiency, and safety. This lecture will discuss socio-technical aspects of healthcare. A socio-technical system is a system in which people and technology interact. These interactions can be straightforward or they can be quite complex. Organizational characteristics of the socio-technical system are modified by this interaction for better or for worse. Optimization of one element in this system, either the social element or the technical element, without close attention to the other element, may be detrimental to the organization itself. Medicine and technology are closely interrelated, and one could argue that medicine has traditionally been dependent on technology for its progress. One example that illustrates this is the story of the microscope. This story begins in Italy in the 14th century, when advances in optics led to a better understanding of lens making. In 1590, the Dutch lensmakers Hans and Zacharias Janssen developed the microscope. 85 years later, in 1675, Anton von Leeuwenhoek examined blood, insects, cells, and bacteria under the microscope. In another advance, in 1938, Ernst Ruska developed the technique of electron microscopy, which allowed researchers to gain a detailed understanding of the structure of organs at the subcellular level. Each development in technology led to an advancement in medicine. Clinicians have historically integrated technology into their practice of medicine. For example, in 1816, René Laennec invented the stethoscope. The stethoscope has been considerably refined since that early prototype. It is now lighter. It has improved acoustic properties. A diaphragm was added, and now an electronic version of the stethoscope is available. Clinicians have uniformly adopted the iterative modifications of this technology into their practice in order to improve patient care. Technology is now the primary driving force of medicine. A vast array of technological resources are available in clinical practice, surgery, radiology, pharmacy, assistive technology, and medical education. The availability of an electronic health record has changed the paradigm of medical information collection, storage, and recovery. Technology has assisted researchers in the design and evaluation of their research projects and has even promoted the evolution of the scientific method. For example, complex statistical calculations were once performed by hand, but now software packages such as SPSS are used extensively for the same tasks. Technology helps to advance reproducible scientific breakthroughs. For example, after the discovery of penicillin, technology was key in refining its production and defining how it could be used. At the time when penicillin was first synthesized, stockpiles were scarce, and the penicillin was recycled in order to use it on multiple patients. Technology is also essential to practice some forms of medicine. For example, Robert G. Edwards received the Nobel Prize in Medicine in 2010 for developing the technique of in vitro fertilization. His innovation would have been impossible without the assistance of technology. There has been an explosion in the amount of medical literature published in the second half of the 20th century, and now a vast amount of information is available to clinicians. Much of this information is rapidly superseded by newer, more pertinent data, and because some of this new information improves patient care, clinicians need to constantly update their knowledge base. In the past, clinicians relied on textbooks and on consultations with other clinicians for meeting their information needs. Now there is an increasing reliance on the online database of medical literature that is easily accessible via the Internet. Advances in technology require clinicians to learn new skills. For example, cardiac pacemaker technology continues to change. Invasive cardiologists need to update their skills in an iterative fashion as advances in technology transform the products and procedures that they are trained to use. The primary focus of clinical medicine remains the clinician-patient relationship. The patient and clinician establish this relationship during a clinical visit and foster it during subsequent encounters. Technology is changing this relationship as well, however. Now there is a third focus in the room, in addition to the clinician and the patient, and that is a computer. The following slides examine the phenomenon of change in the context of healthcare. Change is an alteration in organizational structure or organizational function. Organizations are in a constant state of change, yet the extensive use of technology in healthcare hastens these cycles of change. Certain types of technology may be entirely transparent to the end user, and their implementation may be welcomed by individuals and groups. For example, most physicians embraced pagers and cell phone technology because these devices allowed them to be reached and to respond remotely. The freedom to address patient care issues from locations other than the bedside was welcomed. However, some technologies are intrusive and significantly change the workflow. One example is the implementation of the electronic health record in the clinical setting. Clinicians are more reluctant to use technologies that they perceive to be counterproductive or contrary to their clinical focus. As change occurs in a healthcare organization, it occurs in parallel with the delivery of healthcare. This is because clinicians cannot stop taking care of patients while they perfect new systems. In the past, physicians could see patients, write orders, and plan for care without intersecting significantly with technology. Now, with the advent of the electronic health record, the social and technical aspects of patient care are interdependent. Changes in technology require clinicians to make substantial changes to the way they deliver patient care. The converse is also true. Changes in patient care may require changes in technology. Significant change in the healthcare industry is frequently accompanied by resistance to this change. Resistance to change is the action taken by individuals and groups when they perceive that the change is a threat to them. There are generally three phases of change. First, there is a period of inertia, when little is done. This leads to a transition phase, when the change is beginning to be implemented. Once the transition is complete, the organization reaches a new steady state with achievement of the new model. Resistance to change, at least at the outset, is inevitable because many individuals and groups tend to defend the status quo. Several strategies help overcome resistance to change. One key initial step is to involve all stakeholders before implementing the change. Another method is to create effective lines of communication. Resistance to change can also be mitigated by enlisting the aid of champions or enthusiastic people who can help the organization push forward and overcome resistance from naysayers. Organizations can also attempt to alleviate fears that may be contributing to resistance. Individuals and groups should collaborate to solve problems during the transition, and organizations should actively elicit feedback. The healthcare environment is complex, and over time, clinicians develop their own work processes. Clinicians are likely to use multiple tools and technologies to assist them at work. For example, a physician may use a stethoscope, and a radiology technician may use a CT scanner. Technology has become an essential component of workflow. For example, a physician may see 20 patients per day in the clinic, and now depends on the electronic health record to provide data, help answer clinical questions, solve problems, and aid in documentation or scheduling. New technology requires clinicians to adapt their work processes, and this requires complex and often significant adjustments. For example, a clinician who sees a change in the electronic health record will need to learn new techniques to master the software in order to continue to provide the same high level of patient care. The implementation of technology and the process of technological change may have unintended consequences. Changes in workflow may be a step backwards for overall system efficiency. Furthermore, clinicians may be unable to adapt to the change that is occurring around them. For example, in 2002, Cedars-Sinai Hospital in California implemented an electronic health record. This led to a revolt by physicians, and Cedars-Sinai had to abandon the implementation after 3 months. Another potential issue associated with the implementation of complex technology is that outcome measures may not be positive. For example, Children's Hospital in Pittsburgh implemented computerized physician order entry, or CPOE, in its intensive care unit, and subsequently reported an alarming increase in mortality rates. The actual process for implementing new technology is just as important as the technology itself, or the system where it is used. The findings at Children's Hospital in Pittsburgh could not be replicated when other pediatric hospitals implemented the same electronic health record. This suggests that the Pittsburgh implementation was flawed, with devastating unintended consequences. How do organizations manage socio-technical change? They look for the right people to perform the right tasks to lead change at all levels. They ensure that the people in technology work together with clinicians in a collaborative and cooperative way. Organizations make a fundamental choice. Either they adapt work processes to new technology or adapt technology to current workflow processes. New technology can be designed to improve work processes. People may need to adapt their work processes to the new technology, but the long-term advantages offered by well-designed technology may be helpful in mitigating resistance to change. Adapting work processes requires leadership to carefully manage and curate the change. However, adapting technology to current work processes is counterproductive in most cases because there is no significant long-term improvement in care. Although this strategy may help to streamline some aspects of workflow, it is a less agile method and less adaptable to future changes. One primary axiom of managing socio-technical change is that new technology can be designed that will improve work processes, and work processes can be adapted to new technology. Socio-technical change can lead to enhancements in quality measures and improvement in processes. Other improvements in outcome measures can be demonstrated as a consequence of successful socio-technical change. These include improvements in efficiency and associated enhancement of workflows. For example, improving the technology of electronic health records allows better ways to capture information and document encounters. This allows clinicians to spend more time talking with patients as opposed to documenting the visit. New technologies improve efficiencies of processes. For example, using a lower dose of radiation to obtain a CT scan after installing a newer generation CT scanner. Improvements in patient safety and an associated reduction in errors should follow. One example of error reduction is afforded by clinical decision support. For example, the availability of information embedded in the electronic health record helps the clinician make good decisions. Medication errors are also reduced as a consequence of successful socio-technical change. For example, barcoding for medications and for patients can prevent mistakes in medication administration. One additional aspect of socio-technical change is on the job market. There have been changes in job descriptions in the past few years, as well as new openings. There are roles for new experts in healthcare information technology, roles for clinicians who are technologists, and roles for technical specialists who have exposure to the clinical environment. This concludes Lecture C of Sociotechnical Aspects, Clinicians and Technology. This final lecture reviewed the role of technology in healthcare and examined the concept of social and technical resistance to change in the context of socio-technical interdependence. Several challenges and obstacles are encountered when work processes are adapted to new technology, and changing socio-technical processes have various influences on healthcare quality, efficiency, and safety. This concludes Socio-Technical Aspects, Clinicians and Technology. In summary, this unit discussed medical errors and patient safety, the challenges of adapting work processes to new technology, and the resulting impact on quality, efficiency, and safety. This unit also examined the phenomena of social and technical resistance to change, especially among clinicians.